All right, so any questions on any of the HEMONC stuff we covered previously? I know it was a bit of a whirlwind sort of tour of HEMONC, but again, focus on the big picture stuff for these. Because I'm not going to ask you which one of these is most appropriate for non-Hodgkin's lymphoma. I don't know off the top of my head. I have to look up the regimens, right? I have to look up the actual protocols and whatnot when we go over that kind of stuff. But side effects, mechanisms, drug interactions, antidotes, supportive therapy, things like that are really important to know because those questions will certainly come up. So we talked about kind of the traditional sort of immunotherapy. We talked about kind of the biologic kind of function modifiers. The last set of ones we'll talk about here real briefly is the immunotherapy. This is actually things you're going to be stimulating your own host immune system to fight off those cancers there, right? And so you'll see these sometimes not just being used for cancer specifically. You may also see these being used for other things like hepatitis. A lot of our kind of original therapies for hepatitis C especially included some of these immunotherapies. You may see some double duty for these drugs here. But basically, typically these tumor cells may be expressing sort of an antigenic sort of cell surface protein, the receptor, or some other protein that kind of identifies as cancerous. And so if we can have those cells presenting something that the body can react to, we can try to stimulate that immune system. And so as you might imagine, if we're stimulating the immune system or stimulating that inflammatory response, what kind of side effects might you expect to see? There's going to be a lot of inflammation. It's going to look like your body's trying to fight off an infection. It's trying to fight off that cancer. So you're going to see a lot of kind of flu-like symptoms kind of associated with these because, again, you're kind of ramping up that immune system. That's something to think about as we go forward. But the first one we have here is called Interferon. And so there's a couple of different versions you'll see there. And again, these are all protein-based products. They have to be injectables here. We have alpha 2A, alpha 2B. Just know them as interferon A is fine. Just know there's a couple different varieties that are out there. And so its actions will be to directly stimulate things like the cytotoxicity of like natural killer cells. It's going to be stimulating macrophages to be a little bit more phagocytic. We're trying to go after those cancerous cells, and also try and help out with that presentation, right? So when you have those macrophages eating up some of those cancer cells, they can express some of those antigens to try to help further stimulate that immune system there. And so, again, you can see there's several indications where we might use this. Again, a lot of cancers you're going to find here, things like Kaposi sarcoma and hairy cell leukemia, but also notice there's like certain viral indications as well, things like hepatitis C and B. We'll talk about this next semester when we get into like the HIV/STD sort of section there. So we'll talk about this again later on. But even things like multiple sclerosis, right? We'll talk about that during neurology. But again, these drugs will sometimes come back up again and again. And again, you're going to find that these have to be injectables because, again, they're going to be proteins, so you cannot take those orally. And a lot of these tend to be made from recombinant form. So again, it's trying to mimic that natural interferon that we produce. We're going to be producing these in different sources. So in this case, we actually have E. coli we've kind of modified to help us to produce that. Now, what do you think could be an issue if I'm injecting foreign protein in these patients? Anaphylaxis is a risk, right? So again, especially when you have other organisms that are making this, sometimes they have a little bit of their own DNA getting mixed in there, a little bit of their proteins, and so that's again where you can see some risk for anaphylaxis occurring here. So getting into the side effects, these are really nasty drugs from a side effect profile. We'll have things like flu-like symptoms. That makes sense, right? Because we're trying to ramp up our immune system. Myalgias, headache, hair loss. Oftentimes these will diminish over time, but initially they can be pretty bad. And imagine patients may feel worse when you add these drugs on board before they actually start to feel better. So that can be an issue with compliance from a big standpoint. Other interesting things here as well are the mood changes that happen here. And this is actually a big black box warning for interferon, is the fact that you can have these changes in mood. You can have aggressive behavior. This can include things like suicidal, homicidal ideations can be involved with this. So you want to be careful if a patient has pre-existing history of depression or anything like that, and kind of behavioral health issues where this may be exacerbated by the interferon. And again, this would be contraindicated in pregnancy. We don't want to give it to these patients because it can cross over to the fetus. Another one briefly is called Aldesleukin. This is actually recombinant IL-2 or interleukin-2, kind of serving a similar feature here where it's going to be able to help regulate kind of proliferation and further development and recruitment of things like T cells and B cells, etc. And again, by helping with this kind of this stimulation of this proliferation of these white cells, it's going to be able to help with things like turning on natural killer cells. It's going to help to kind of just ramp up the whole system overall, and especially inducing things like interferon, which we saw previously. Again, is another drug we may use in this case here. Again, a lot of these are going to be IV based because again they are proteins. again, recombinantly made E. coli. It's not important that you know specifically where it's coming from. It's just kind of give you an idea of like how do we actually produce these. And again, we've kind of engineered E. coli to produce it for us by kind of modifying their DNA there. Again, just a couple ideas where it's going to be working at, things like colorectal cancer, lymphomas, different things like that. Again, when you work with these specific types of cancers, you become very, kind of well-versed in what kind of drugs you're going to be using for them. Just like I'm very familiar with peds leukemia. We deal with it day in and day out. Every day I'm over at Nemours, and so I know things like vincristine. I know my etoposide, ifosfamide, methotrexate. So we'll kind of get a feel for it if you work with these patients to any given extent. Again, side effects here are very similar to what we saw with the interferon. So again, a lot of fevers, chills, myalgias. This one's kind of interesting here where Aldesleukin, you really want to be careful with monitoring because you can have what we call this capillary leak syndrome. Very, very frequent for this to occur. And so what happens when you have capillary leak? Where does a lot of fluid go? Into the interstitium, right? So again, what does that do to your blood pressure? If you lose that intravascular volume, you're going to get hypotensive, right? So that's why you see this very commonly occurring here. And obviously, you want to give them more fluids to try to help kind of replete the patient. But again, if they're still having those leaky capillaries, may have some issues there. A lot of times they require pressor therapy. Does anyone know when I say pressor therapy what that refers to? And vasopressors, right? So again, there's going to be things that are constricting the blood vessels. Have we talked about any vasopressors at all yet? Nitro, is nitro a vasopressor?
No, sorry, not vaso.
There you go. So that's actually the opposite. Vasodilator, right? Would be a vasopressor. What do we use for anaphylaxis? Epinephrine. That's a vasopressor, right? We know that activates alpha receptors. It's going to cause vasoconstriction there. What else have we talked about? Vasopressin is another good one, right? Vasopressin is another name for that is ADH. You know that's going to be causing some vasoconstriction there as well, right? Along with some fluid retention. So we've already covered a couple of these previously, even if we haven't talked about them in the specific setting of acting as vasopressors. And we'll talk about those at a later section in Pharm too, but kind of keep some of those in your mind. Other ones, norepinephrine. We can give norepinephrine IV, and that can also act as a vasopressor. We talked about dopamine briefly. That can be used as a vasopressor. So there's a lot of different options that are out there. Remember how I talked about phenylephrine? What did I say about phenylephrine previously? We talked about an ENT. It's a bad drug, right? It's bad orally. However, I can give it IV. It's a great vasopressor. It's a direct alpha agonist. You can see a lot of good increase in blood pressure from that. So anyway, just a little bit of a tangent there. But again, hypotension is a big thing here. You may require that therapy to try to get their pressure back up, right? Now, again, when you have hypotension, what does the heart want to do to compensate for that? You get tachycardic, right? When you get tachycardic, what can you induce? An arrhythmia potentially, right? Especially if you have a kind of an aggravated heart, any kind of altered electrophysiology there. So arrhythmias are a possibility here. MI, worsened heart failure. So again, you can see why a lot of these kind of cardiovascular symptoms are coming about from this hypotension there. And then CNS effects here as well, mental status changes, seizures, coma. Some of this can be due to that CNS edema, right? So again, increased pressure there on the brain can cause changes in mental status. Again, that goes back to that capillary leak. So you got to be really careful with that. Not with the ADH necessarily, but it's more the vasculature just becoming more leaky. That fluid's going to leak out into the CNS as well, and so you're going to have that pressure building up there. Yeah, basically. Again, so these are nasty drugs. However, when you need them, you absolutely need them. So very specific indications when you're going to institute these. But again, the goal is just to give you some ideas of when different options you may see out there. And again, be very cautious in patients' cardiac pulmonary conditions because again, seizure disorders, because these can all be a risk for them. Okay. So let's look at, that's kind of the end of the drugs. We're talking about specifically as treating the actual cancers themselves. Let's look a little bit about some of the other things that go into how we're managing these patients. So dosing and administration. So as I mentioned, many regimens are count dependent. What does that mean? Yeah, so oftentimes not necessarily red blood cells, but most of the time what we're looking at, that can be a component of it. But, you said white blood cells. There you go. Perfect. You need a microphone too, just so I can hear you. But yeah, white blood cells need to meet certain criteria. Usually the neutrophil count, we're looking at absolute neutrophil count when we're looking at that is meeting a certain criteria, right? So we have to make a certain absolute neutrophil count very frequently. We're also monitoring their platelets as well, right? Because again, if you have low platelets, you're at risk for bleeding, bruising. It's no good, right? So you want to be careful with that. So that's usually what we're going to be monitoring for. Because again, anytime we're giving, especially these traditional chemotherapy regimens, you're going to be knocking down their immune system, knocking down their blood cell production, and you need to give them time to recover. And so by the time they meet those counts, then you can give them another dose of drug, essentially. You have to monitor organ function, so things like renal function. What drugs might that be important to monitor renal function for? Methotrexate's a big one, right? Kind of go back and review some of these things like, cyclophosphamide, important for bladder dysfunction, but also you can see some kidney stuff there. The platinum-based drugs. Think about kidney function for these. Looking at things like urinalysis, right? Looking at things like hepatic function. These are all important monitoring things we're going to be looking for. What other things might you want to monitor for before you initiate chemotherapy, say like on a female patient? You may want to check a pregnancy, right? You want to think about things like that because, again, we said all these cancer drugs are what? Teratogenic. They can cause damage to the fetus there, right? That makes sense. So you may want to check a pregnancy, especially when you're initiating therapy, depending on the patient there. Now, how the drugs are actually being dosed, you have to be really, really careful with this. These are some of the most high-risk medications you're going to be dealing with because, again, essentially they're poisons. And so you have to look at things like, how are we dosing it based on the age of the patient? We have, especially with peds, this becomes more important because we'll have different parameters of like, if they're less than 1, then you dose it this way. If they're greater than 1, you dose it this way. Right? You can have things like, dosing being based off not just their weight in kilograms, but also in their body surface area. What's kind of the benefit of body surface area being used? I talked about that briefly in peds back in like the intro to pharm course. Remember, what does BSA take into account? So it takes the patient's weight into account, but also what? Their height as well, right? So again, you're going to find that by using height and weight, you're going to find that even kids who may be in either extreme of either underweight or overweight, that takes you kind of lessen that effect a little bit as far as your drug dosing goes because you're also taking into account their height. So based on that, usually you'll get your value coming out as meters squared, and so you may dose it, say, for instance, like vincristine, I just know it's 1.5 milligrams per meter squared for these patients, right? That's most of the regimens we run into. You don't have to know that number specifically, but just know that BSA is very commonly used. And in fact, I think on your prescription assignment, I put a drug that was dosed off of the BSA. Okay. Now, I know whenever you're calculating these things, there's multiple formulas that are out there. So be comfortable with whichever one your organization is using, right? So, for instance, we use the most stellar BSA calculator. That's what I told you to use on the prescription assignment. So think about those things, right? And then, of course, some of them are just going to be weight-based, but a lot of times we're using BSA to dose our drugs here. As far as safety and handling, now are chemotherapy drugs just dangerous to the patient? No, they can be dangerous to the people who are administering it as well, right? So either providers, the nurses, whoever is going to actually be handling the drugs here. So proper PPE has to be used. Now, is it just the actual handling of the drug that should be considered? No, when you give chemotherapy to the patient, any of their excreta can be potentially contaminated with drug as well, and that could also be carcinogenic to people who are handling it. So you have to make sure you're wearing things like gloves, gowns, shoe covers. Again, you want to get a bunch of like doxorubicin on your shoe and carry that home with you. It's no good, right? Things like if you're worried about aerosolization of drug, right? So again, if your patient, happens to be coughing a lot or is using anything that could be a lot of aerosolization, make sure you're wearing a mask and eye protection. That can be really important as well. As I mentioned, patient excreta should be considered hazardous, right? So like wet diapers or their stools, urine, anything like that needs to potentially be considered hazardous. A lot of it depends on the type of chemo being given, right? So especially the traditional ones tend to be a little bit more hazardous there, and also can depend on the time frame when the last time they got their last dose of chemo was, right? So again, usually for some period of time afterwards, they still consider it to be hazardous, and then after that period, you can consider kind of normal handling procedures at that point. Now, just as important as the chemotherapy is also the supportive care to make sure we can kind of help maintain our patients' overall health. And so this is where things like from a hematologic standpoint, we know that myelosuppression is going to be a huge aspect here with a lot of these traditional chemo drugs. And so what we can do is try to give them medications to try to help stimulate that, try to help them recover a little bit faster, right? So for instance, when looking at this myelosuppression, it generally takes time to develop there, right? And so you're going to find that the white blood cells deplete typically faster than the platelets, and that has to do something with the lifespan there. So again, 6 to 12 hours versus 5 to 10 days or so. So oftentimes you're going to see the ANC drop sooner than you would the platelets necessarily. And then for an anemia though, because again, are the chemo drugs directly affecting the red blood cells that are already formed or the ones that are going to be formed? To the ones that are going to be formed. So if you see an anemia, typically it's going to be more of a kind of a long-standing sort of thing over several months, because we do know that red blood cells last for about how long? 20 days or so, right? So they stick around for a little bit longer there. So that can be something you see over time. And of course, increased risk for infection. If your white blood cells are down, increased risk for bleeding. If your platelets are down, increased risk for, anemia if your red blood cells are down, right? So these are things you have to consider there. One thing I do want to make special note of here is you can only give certain routes of drugs to these patients based on some of their counts. So for instance, if they're neutropenic, you do not want to give anything rectally. Now, why do you think that is? I think it may not absorb that. That's not really the case there. So imagine what lives in the rectum. A lot of bacteria, right? Amazing. Not my rectum. Mine's clean as a whistle. I guarantee you it's not. There's a lot of bacteria living there. So imagine what would happen if you have, and again, if you say, for instance, we're trying to give a medication rectally, or maybe, for instance, you're trying to take a temperature rectally, right? You're inserting a probe rectally. If you were to cause any damage to that mucosa, say, for instance, you have a few platelets there, so you can't necessarily clot that off very well. All of a sudden, those bacteria can do what? They can translocate and they can have a hematologen spread from there, right? So again, infection risk is huge. So you do not want to give anything rectally. You do not want to put anything in the rectum when they're neutropenic like that, due to the infection risk that can happen there. So be really careful with that, which is important because imagine if I have a patient who is receiving chemotherapy and they have all this mucositis, so they can't really take any medications orally. Oftentimes using something rectally can be a really nice alternative to that, right? From giving like rectal acetaminophen, if I want to check a rectal temperature, that can be a very useful thing. However, if they're neutropenic, it's going to be contraindicated. You don't want to do that. Even things like, your friend or family member is sick, they're in the hospital, they're receiving chemotherapy, I'm going to come bring them some fresh flowers. You don't want to do that either, right? Because unless you can bring them fake flowers, it'll last forever. That's what I think the benefit of fake flowers are. But apparently wives don't feel the same way. That's okay. However, if she was receiving chemotherapy, I would not bring her fresh flowers because of things like bacteria and things like that that can grow on it and can propagate. Even things like fruits. Fruits that can be peeled, great. I can give them an orange. But something they're going to just bite into, maybe not so good, right? Because again, you can have bugs and stuff growing on the surface there. And so again, this can just be corrected with time. And occasionally we can give them replacement. So again, if we have to give them an infusion of our blood cells or something like that, it's possible. Or oftentimes we'll give them colony stimulating factors, right? So for instance, what do we need to stimulate red blood cell production? EPO, right? So we can give things like erythropoietin. I can give things to help replenish some of my things like granulocytes by giving GM, CSF, or GCSF. So if you ever see CSF, that is in some cases cerebral spinal fluid, but in this case it's colony stimulating factor here to try to replenish these cells here. So this is really important, and oftentimes that'll be included as part of the regimen. Give them chemotherapy, knock their immune system down, and then give them replacement factors to try to help stimulate their own production thereof. From a GI standpoint, nausea and vomiting is super common with chemotherapy. We even talked about that anticipatory nausea and vomiting you can develop after receiving chemo several times. You're just like, oh, I just know it's going to happen. I just know that feeling I'm going to get nauseous again, right? And so we'll talk about antiemetics further in GI next semester, so don't worry about that necessarily. But mucositis is very important here because one, this can limit intake, both liquids and nutrition, and so be very careful with that. Infection's a risk here as well, and so this is where oral hygiene is really important. Things like warm saline rinses can be useful, and then also there's an antiseptic called chlorhexidine or Paradex that we use orally very frequently, try to make sure to clean the mouth out, make sure they're not going to be at risk for developing infection due to that. And just to give you an idea of the different immunogenicity, just a fancy way of saying how likely it is to make you nauseous and vomit, you can see here that not all drugs are created the same. And don't memorize this list at all. I just want to kind of show you that they get stratified based on the type of drug and sometimes based on the dose you're receiving. So for instance, we know things like cisplatin, huge amount of nausea and vomiting associated with that. We may have to give them 3 or 4 drugs to try to help manage that nausea and vomiting, versus something that may only have a moderate risk, maybe have to give maybe only 2 drugs for it. So again, you'll look at that when you see these different regimens based off of, most of the time it's based off the immunogenicity of those drugs there. Okay, as far as the skin goes, obviously alopecia can be pretty traumatizing to the patient there, very distressing. There's really no good pharmacotherapy for this. We don't really recommend Rogaine or anything. It's just over time, once they get past the chemotherapy phase, will grow back. And then from an extravasation standpoint, what did I say about that? What is that? And drugs are getting outside of the vein essentially, right? So if you blow a vein or whatever happens there, basically this is no good because a lot of these drugs can be called vesicants and cause severe tissue damage. You have to be careful with those. As I mentioned, anthracyclines, like, remember what falls in that category? Like doxorubicin, daunorubicin, mitoxantrone, those are the big ones. Those are extreme vesicants. Vinca alkaloids like vincristine and vinblastine, the taxanes like paclitaxel, those all are extreme vesicants, and you have to be really careful with those. Again, a lot of times we can either do it with hot compresses, cold compresses, depends on the drug. And even sometimes we'll give them things that will help to absorb it a little bit faster. So for instance, we can try to break down that connective tissue subdermally to try to increase that absorption there. So we give a drug called hyaluronidase or Hylenex, and actually helps to break down that connective tissue and allow it to be absorbed a little bit faster. So just know there's different regimens there. Everywhere you work, if you're dealing with these drugs, you will have a protocol set up that will help you with that. Because again, you don't want to be, you don't have a nurse call you up and say, oh no, this drug's extravasating, skin's starting to look pretty bad. What do you think we should do? You want to have a regimen you can go to. You don't want to sit there and try to look it up. Like, you want to know what that protocol is. Okay, so that is it for chemotherapy. In the oncology section, any questions I can answer. I'm sure you've thoroughly reviewed it since last time we talked. I know you're going to be experts when we cover the Kahoot.